Welcome to Black Health Matters. I'm Darryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
From 10 to 19, which means that the girls are being infected by men with HIV, and it's important that we educate our young ladies so that they protect themselves from the men who are spreading HIV, because it's so disproportionate that 70% of the people between the age of 10 and 19 who get HIV are women, are young girls. And so I know talking doesn't do much, but at least you can try to educate and empower the adolescents as they are growing up. I don't know how many of you have girls, but it's an important information to share, because as they write about it, they think that it's pretty disgraceful that 70% of the people who get HIV between 10 and 19 are women, and adolescent girls, often underage. So I thought that was an interesting article, and something that we parents and grandparents who have young ladies can share, although discussing that information is not easy, but it's something that I thought we should be aware of. Any comments or thoughts about that?
If you think of a 10-year-old, you're thinking of a fourth and fifth grader. And it used to be we would think of junior high and high school kids. Now you're going all the way down to middle school kids and younger. At one time they said even 9-year-olds. So if you think that is really drastic, and I know talking to some girls and boys, they were thinking, and I guess it's changed now, they were thinking that if they had oral sex, that they really weren't having sex. So, and I learned that in a Sunday school class. I know. But the point of it is education. And like Dr. Callender said, that's a hard subject to broach with parents and particularly grandparents, because they just don't expect grandparents to even mention the subject. But how else are we going to warn our children?
My question is that there is something that can be done if you contract HIV. However, the solution is not to get rid of it completely. Is that correct, Dr. Callender?
An ounce of prevention is worth a pound of cure. We say that time and time again, but this is a good example. Yeah, there's treatment now for HIV, but that doesn't mean that you should get it. You should prevent it rather than getting it. It is wonderful that it's no longer a death sentence, but it's still an infection that can be avoided. Okay, I just wanted to share that with you all. There's also an interesting article that you might like that talks about some easy ways to eat less salt by using herbs and other spices to avoid the use of salt, which of course is associated with high blood pressure. Mark, you had a comment.
Just very quickly about the last subject. The way to broach those conversations as parents and even as grandparents is to talk about their media consumption. I think we all kind of know that sex is everywhere, just to put it bluntly, in music, in movies, songs. So even if it's just a question as far as what are they listening to? What are they watching? Those are, I know it's kind of uncomfortable or awkward conversations, but that's a way to start. You don't have to just come out and say, "Hey, so what do you think about sex?" You don't have to come out the gate, but just start with what they are consuming, but with the media, what are they looking at, and then just kind of talk about it from there, however you feel there. But that was just gonna be my suggestion for that.
Like TikTok.
Definitely TikTok. Definitely TikTok.
Thank you for those comments. Okay. I guess we can start the
I think
articles.
John Tatum has something. You want to do that first, John?
All righty. Let's start with the picture, I believe, and then we'll go to the article that goes with the picture.
Side picture.
Yeah, Betty Blaylock sent this to me.
That's Dr. Odocha is one of our transplant surgeons, and young John Tatum and Edward DeSella 30 years ago, huh? And 30 years ago.
30 years.
He had received his transplant in July.
That was October.
Yeah. Yeah, the date is wrong. Huh?
No,
Okay.
it's an article after the fact.
Yeah.
Yeah. It's can you hear?
Did you know John would look like that 30 years ago? Slim and trim, handsome.
Can you hear me talking?
Yes.
Yeah. This article was in a Howard University newsletter in October 1993.
Oh, okay. 93, huh?
Yeah.
Yeah, that's interesting because we conceptualized MOTEP in 1991, but got our first grant in 1993.
That's my Aunt Sarah in the white hat.
Yeah, I was getting ready to say that was Aunt Sarah.
Yeah, that's what caught my eye when I saw the picture before John really even. I saw Aunt Sarah.
How about that? Yeah. Wow.
Dr. Callender, the front of the newsletter had an article about a doctor who had come over from Africa to get a transplant from Dr. Baptiste.
Yeah.
Oh. Yeah, boy.
His name was Dr. Baptiste.
Yeah, I remember him. Yeah.
He was a dentist.
Yes. And Dr. Truant,
he taught me.
Truant gave him the transplant.
Toussaint.
Toussaint. Yes. That's the front of the page, the front of the art.
Okay. It's amazing you guys remember the article from all the way back then. This is in 1991 we conceptualized National Minority Organ Tissue Transplant Education Program as a consequence of our work in the District of Columbia, where we started a program, the first of its kind in the African American population, because people said that African Americans would not donate, but we needed organs and tissues more than any other ethnic group. So it was important for us to become part of that situation. So we conceptualized, therefore, doing the same thing that we did in the District of Columbia and the DMV areas all over the country. And so we actually got funds from the Dow Chemical Company to go across the United States, 25 cities, to talk about the need for donation and the fact that people of color needed to be part of the solution to the problem. And so we then conceptualized this idea. We went to Congressman Lewis Stokes, who then introduced me to John Ruffin and the Secretary of Health, who was Lewis Sullivan. And they identified some funds that they would allocate for us to start a program, first in New York and DC and Cleveland, and then across the United States, 15 sites across the United States. And all we were doing is to educate people of color about the need for organ and tissue donation, something that we need more than any other group because of our predilection to high blood pressure and diabetes. And it's interesting. It began then, and because of the funds that we were given from National Institutes of Health over the next 15 years, we were able to receive some $15 million and to start an effort that doubled the number of minority donors across the United States and quadrupled the number of African American donors in the United States. So it all started then and there, and it's interesting now, some 30 years later, we're still at it.
Mm.
Yeah.
You
So
don't have a secretary for MOTEP right now. Is that right?
say again?
Joyce Tatum Brown used to be your secretary at MOTEP.
Yeah, she was one of the early members of our efforts. She worked for the Department of Health and Human Services. That's where I first met her. And she was a Lone Ranger then. And as we worked to try to educate people of color, she played a major role in terms of getting information that was published that we could share across all venues. So she's one of the early founding members of MOTEP, and she played a major role in us getting information across the United States. So thank you for those two articles that show how time flies and how, in spite of many changes, we're still at the job, still at it. Actually, this group was one of the earliest, well, no, was the earliest transplant support group. Actually started in 1975, so that goes way back. And you can see, you know, in that picture there, that was the time we had the patients and their relatives that were part of the group, because we realized that in order to make sure that they took care of their medications and kept the transplant, that we needed the family members and everybody else to understand the complexities of end organ failure and how it sometimes made you more irritable and made you hard to get along with. But in spite of that, people like Carol have blazed a trail and stayed up with their irritable and unpleasant husbands and spouses and kept them alive. And that's the story. Carol is an angel, and John bears the fruit of the angelic presence of Carol Tatum.
Mhm.
Amen.
Yes, indeed.
Very well said.
Amen.
Okay,
Yeah.
Carol will never forgive me for saying that, but that's the truth anyway.
Mhm.
By the way, I saw Maya Thorpe yesterday, who was a member of the group, has been off and on a member of the group for decades now, and she's doing well. Her husband is sick, but she's doing well nonetheless, and still working at Howard with the group that meets every Wednesday. So, okay, we can go to the next article.
Is she still working as a chaplain?
Yes.
One question before you move from that subject. Can you tell me, Dr. Callender, when did the transplant center at Howard close?
2010.
It did. I
Yeah.
don't mean the center, the dialysis.
Oh, November 20th, 2023.
Oh, okay.
Yeah, it just closed. Yeah, it's just closed. That's actually, we started that about 50 years ago. So to see that it's closing now is an end of a historic occasion that has been associated with little publicity, but in many ways it's a sad day that the 50-year history is quietly ended, because that was a great service to the community. But anyway, all good things come to an end. So, yeah. Okay, this is an article that talks about something that we've been working on for the last 3 years or so, and that is to try to get more people of color in the transplant system, in the transplant industry, because it's not enough for us to make up 60% of the people who are waiting for the organs, but it's important that we actually are part of the system. We want to at least double to triple the number of people of color who are actually in the industry, particularly at the top. We're at the bottom, but we should be permeate throughout the issue because we're so commonly affected by high blood pressure and diabetes, and then organ failure. And to this end, this article talks about the fact that we make up so few of the 5.5% of the transplant community as transplant surgeons, and while we make up 28% of the wait list and account for 16% of deceased donors, while that's more than our percent of the population, it's still something that we need to work on. So that it's important that we have more people of color in the transplant system at the top and throughout the organization. And so we talk here about two programs. One is a program that is at Meharry, in which 6 students have gone into the organ procurement organization and learned what it's all about in terms of getting people to sign, to become donors, also to see what the surgery is like to take out organs and what it's like to talk to families who have lost their loved ones and get them to become donors. And this work that has begun there has impacted those 6 medical students to become a major part of the industry, and that's what we're all about. We at Howard are interested in, we've developed videos and actually have developed a curriculum that we're going to start at Charles Hart Middle School in late January of next month. And this curriculum is intended to educate parents, their teachers, and the students about how they can become part of the transplant industry, because it's important that we have more people of color at all levels of the transplant system. Recently, it has been identified that there's a lack of transplant equity in transplantation, too few people of color. And so this is our effort to change that and make a difference, something that we think is important, but something that has not yet occurred. Any comments or questions about these
Dr.
efforts?
Callender, yes, I do have a question. When colleges offer not health fairs, job fairs, are there people in the industry going out to these job fairs and discussing the need and the demand for people in this industry?
That had not been the case in the past, but that's something that we need to work on in the future, because and our effort starting in the middle schools is trying to accomplish just what you're talking about, because in the past there has not been an effort, particularly an effort that emphasizes the need for people of color to be involved.
Yeah. I thought that the books that you all have that's going out to the younger kids, the younger students, is a good starting point to get them to understand and realize that there is a need. And I thought that was a good starting point.
Thank you very much. And it's going to be interesting to see how it works in the middle school, and when we're successful there, how we can get it to other middle schools and to elementary schools as well, because The need for equity is something, diversity begets ingenuity, and the greatest weapon that we have as human beings is diversity. And so the more diverse we are, the more likely we are to survive all efforts of the viruses, the bacteria, and the protozoans, and even our own efforts to resist diversity, because diversity is one of our greatest strengths.
Dr. Callender, did you mention Charles Carroll Middle School?
Charles Hart Middle School.
Charles. Oh, okay.
Charles Hart Middle School, yes.
Where is that? Oh,
that's
Hart.
right in the Black
In
community.
DC. Right in
DC, yeah. Okay.
Right on, it's located at 4th and Mississippi Avenue Southeast, right in
That's
the
right.
Yeah.
Carol, you taught there.
Anaconda.
Yeah.
No, they said Hart.
Yeah.
I was
Yeah.
at Charles Carroll, but that's
Yeah.
Hart Middle School.
All right. Connie,
right.
that's where Connie used to work,
Mhm.
John.
Oh, yeah, George Parker.
Yeah.
Dr. Callender, where's Meharry?
Nashville, Tennessee. That's where I finished medical school 60 years ago.
What?
And I was honored to give the opening school address in I guess it was October, after having 60 years of being a graduate of there and going back and giving the opening address is one of the greatest honors of my career so far.
Wow.
That's great.
Dr. Callender, what motivated you to want to work in this industry?
It's an interesting question that you asked, because actually my life's goal was to be a medical missionary. And so as soon as I received my surgery degree, I went to Africa and spent 1970 and 1971 in Africa. But when I came back, I'd lost 50 pounds. And the first time I lost 50 pounds, second time I lost 25 pounds. So it sent a message to me that maybe my life work would not be in Africa. And so with that in mind, I decided to go into a field that was new in 1971. And that new field was transplantation. I was interested in transplantation because Bill Mattori, who was my mentor at Howard, had taught us how to do transplants in animals. And actually, around that time, transplantation was just beginning. And so I thought this was a new field, exciting field. And I thought I wanted to become part of it. Since I didn't fare so well in Africa, I thought maybe coming back to the United States and working in transplant would be something that I'd like to do. So that's how it happened, because my whole life's dream was to become a medical missionary, not to be a transplant surgeon. So that came on later.
What was the cause of your weight loss?
Never found out. I suspect it's the fact that everything I ate went right through me, because the food was so hot and spicy. But we never found any pathologic findings. No diseases. So.
Hey, maybe some of these obese people in America need to go there. Where were you?
I was in Lagos and Port Harcourt, Nigeria. Yeah.
Oh.
Yeah. So that's the story. Now
Dr.
this
Atto is a very thin man too.
huh?
Dr. Atto is a very thin man. He's from Nigeria.
Yeah. I guess he's not here yet, but this then is, we had sent a letter to the Congress of the United States complaining about the fact that they're trying to bring profit into the transplant system. And the original transplant legislation was opposed to that. And this new legislation that we fought against was signed into law. And this article just talks about how that they were very upset that they were not going to have profit in the system because that's what the new law requested. And so Senator Grassley got on the Senate and decried the fact that they were slow in adding profit into the system. And so with that in mind, I responded because I had already sent a letter that I shared before that talked about the fact that I was a member of the original Transplant Task Force. And one of the things we wanted was to keep profit out of the industry because profit making is the antithesis. People who leave organs and tissues behind in life and after death do it because they want to help others, not because they want people to make money. And we felt that profit should be, that it should be non-profit people who are calling the shots and not people who are just in it to make money. And so this then was, as a consequence of that, we sent this letter from MOTAP decrying his position and pointing out that even some of the work he's done suggested that when profit is brought into the system, the quality of health decreases. And therefore, as far as it relates to the healthcare system, the nonprofit situation should continue. And this is my strong letter, MOTAP strong letter, indicating to them that we felt that they were taking people in the wrong direction, and that organ donation is a gift that people leave behind, and profit should play no role in this, and that it should be a nonprofit. And so this long article is actually reminding them that once again that this is something that should not be profit driven, but should be quality driven. And so it's a long letter, but it's a letter that calls into question why they want to have profit in the scheme. Most people want profit in the scheme because they want to make money. Well, we think that this is not the right way to go, and that's what this article is all about, pointing out that this is something that we should not do lightly, recognizing that bringing profit into this situation causes problems. As you know, you can buy and sell organs in other countries, but it's illegal in the United States.
Right.
Any comments about that? Any thoughts about the role of profiteering in medicine and health? I think most of the studies that have looked at the profit motive in health have identified that when profit is the issue, quality decreases. And so that's the position we were taking. Any comment on that?
Yeah, my comment, your letter seems to have made an effect. And so, you know, the letter did some good.
Well, time will tell. We never got a response yet. So, you know, he expressed himself, we expressed ourselves, and so the question is, what happens next?
Yeah, that was my question. It's still on the floor then. That's what you're saying? The change is still on the floor?
No, actually, what has happened is that the new law suggests that profit should be involved. Now, the HHS, the Health and Human Services, have not done that because they didn't agree with that. So that's why he got on the Senate and protested, because he wants profit to be an important part of it. And we, as Mark Tatum has said in the chat, the love of money is the source of all evil. And we taken a position that we do not want that to happen.
Oh, so the law has passed and you all are trying to get it reversed. That's what you're saying?
No, I'm not trying to get it reversed. I'm just trying to keep profit out of the industry. Now, he wants just the opposite. He wants profit to be involved. And we want profit not to be involved. The law is already passed that allows profit to be in the industry. So that, but that doesn't mean you have to do it. It means that you can do it if you want to. And we are saying we don't want that to happen.
Okay.
We're not saying to reverse the law because the law is already there. The law says that you can do it if you want to do it. It doesn't require you to do it, but it says you can do it if you want to do it. And our position has always been that that should not be the way to do it.
Okay. Very good.
Okay.
Dr. Callender, there are so many people that are morally bankrupt that are in charge that we need to be vigilant and keep our eyes and ears open and always confront immorality when it comes to things like that or anything. But people have to speak up and they have to be involved and not be complacent.
Well spoken, well spoken. And that's the position we've taken. Thank you for supporting it. Because if we're silent, then that means we're supportive of it. And
Right.
we're not supportive, so we have been outspoken. And so in many ways, that's what MOTEP has been able to do. So we shall see what happens. Okay, I hope all of you have gotten your vaccinations. Because if you haven't, you should have by this time, because between December and February is the peak of the fight against respiratory illnesses. And with the three vaccines now, we didn't have RSV before. We now have RSV vaccine, COVID, and the flu. So between those three, this should help us not have so many respiratory infections. However, this article is decrying the fact that so many people have not gotten the vaccine, the three vaccines. And as a consequence, the rate of hospitalizations and deaths from these respiratory illnesses is increasing. And so they're trying to urge as many people as possible to get all three of the shots, three of the vaccination shots. You see that only 16% have gotten the new RSV vaccine, and that's very low and very disturbing, especially in people over 60. Now, this is an article that talks about what I've talked about for quite a while now, is that the high-dose flu vaccine is important for us older people whose immune systems are slowing down. And that this is true for those who are over 65. It may be just as true for people younger than 65. But certainly for those people over 65, when you get your vaccine, you should make sure that you ask for the high potency vaccine, flu vaccine. We've discussed this for some time now, and sometimes physicians neglect to tell our seniors, people over 65, that there is a high potency flu vaccine that is specially armed for them. And so this article just reinforces what we've talked about for some time. So any comment or thoughts about the fact that so few people are getting vaccinated?
I was I was out at the store yesterday and I noticed that quite a few people were wearing their masks.
Yeah,
I didn't
and
have mine, but quite a few people were
well, that's
wearing their
good because the CDC has come out and reminded us that this is the season to start wearing masks again. Still not that many in churches. I think maybe about 50%. It's now up to about 50% of people in church wear masks. And as we go from November to December, December to January, the number of people with the respiratory infections is going to increase. And HIV-1 subvariant is the number one. And the vaccine is protective against all of these.
Dr. Callender, I had taken the single dose at first because I think that's because that's the only thing my primary care doctor had on hand. But then later I went back and got the senior dose. But there was a difference in the pain too. The senior dose site of injection was a little bit more painful and lasted, the soreness lasted a little bit longer too. I remember that.
Okay, any other comments? If not, it's important that we all get vaccinated. Of course, there's always a segment of the population does not believe in vaccines because of side effects. So. Now, this is an article that we've often wondered about whether hypertension, heart attack, and strokes are higher in the winter, and why? Since they are, why would they be higher? And this article talks about the impacts of cold on the immune system and on the physiological aspects of health. And it points out that SAD is still around with us, and that hypertension gets worse. Coronary artery disease gets worse, and the constriction that occurs as a consequence of the cold is a significant factor, because when your blood vessels constrict, that stresses the heart. And as they constrict, then it raises the blood pressure. So yes, it is correct that this is the time of the year where chest pain, heart attacks, hypertension, strokes are more common. And what do you do about it? I guess you should try to stay warm. Yeah. Most of the studies will demonstrate that, yes, it is a fact that in the cold, heart attacks, heart failure, strokes, all of those
Thank you.
increase your heart risk. So you bundle up. That's something we all learn. Of course, if you live in Chicago or Wisconsin or Minneapolis or any place in Minnesota, you learn to warm up. Yes, you can exercise safely in the cold, but there's evidence that cold showers and swimming in the cold is beneficial. I don't have the heart to do it, but people like people have talked about it for some time, and And I guess we've had a number of studies that have demonstrated that taking cold showers, swimming in cold water is something that has immense positive effects. And that doesn't mean that shoveling snow does not cause heart attacks, because we do know that that is a common problem. Mark and John, you had comments.
So yeah, just jokingly, that whole cold shower, being cold baths and all that, that's for the young people. I heard that uh, actually being in a steam room or sauna room, I was looking into that research saying that actually does a lot for blood pressure issues. So to me, that seems like a converse kind of thing, you know, because being out in the cold is one thing, but also being in those kind of super warm environments can actually be helpful as well. What are your thoughts about that?
Yeah, okay. John, you had a comment? You're on mute.
That's ironic. The father and son had the same comments. My comment was about there's something that needs to be said about steam and warmth when it comes to opening the pores of your skin and getting clean that way.
Okay. Father and son, one and the same.
What about opening your pores of your skin with the steam and the hot water, opening up so that you can get a deeper clean?
Okay, no argument there.
I'm asking.
Yeah, I think there's evidence for both. So
Okay. Thank you.
this is an article that still emphasizes that the control of the blood pressure is the largest contributor to global cardiovascular disease, and we can't overemphasize the importance of monitoring your blood pressure and continue to take medication that keeps your blood pressure under control, recognizing that if you have a blood pressure that exceeds 130, that it needs to be controlled by whatever mechanism. Some people believe that exercise will do it. If it does, that's fine. But if not, medications will do it as well.
Mm-hmm.
And one of the things that is important is that the blood pressure should be controlled. And the only way you can know that is by monitoring it, by taking it, your blood pressure at home, having a blood pressure apparatus that you can take yourself. And if your blood pressure stays below 130, you're in good shape. If it's above, then you need to get it to the point where it is less than 130. We've heard a lot of discussions about what is the desirable blood pressure. And there have been studies that demonstrate if you keep it under 120, that's best. And I don't think there's too much argument about that. Many people would say that if you shoot for less than 130, that you're okay as well. But the best, most of the studies that have been looked at have demonstrated that if you have a blood pressure less than 120 or less, that's the ideal. Any comments or questions about that?
I had a question, Dr. Callender. Can anything be said about raising your blood pressure a few points by the stress of squeezing that bulb on your blood pressure cup?
No, I've never heard anything about that. Have you?
No, but there's no way to tell. If you give your own self that blood pressure cuff and you squeeze it yourself and you get your reading, there's no way to tell whether squeezing that cuff like that caused your blood pressure to be up slightly.
Well, there's no evidence that that is the case. So I've not read any study that said that using the blood pressure apparatus caused hypertension. Now, this is something that I thought would be interesting if we can get it to work, because we talk about liver and pancreas screening, but actually trying to get ways to screen for liver and pancreas is not so easy. We talked before about the fact that they have a liver screen, but liver scan that looks for fibrosis, and they have liver tests.
Let me come out of this for a second. Let's see. Stop share. Go back to the share screen. Okay, there we go. Share sound. Optimize for video clip. Go back to it and see if we can hear it this time.
A lot of patients don't know that there are screening tests for some cancers that primarily affect the liver and the pancreas. In terms of liver cancer, most patients have heard of colorectal cancer, which can sometimes spread to the liver. However, screening tests also exist for patients who have cancers that primarily arise in the liver. And these are more often called hepatocellular carcinomas, or HCCs. Patients are at higher risk for developing this type of liver cancer if they have a chronic liver disease, such as cirrhosis, or a prior infection with hepatitis B or C, or sometimes from chronic alcohol use. Cirrhosis just means scarring of the liver. For patients who have this diagnosis, it's recommended that every 6 months you undergo a liver ultrasound and a tumor marker test known as alpha fetoprotein, or AFP, and this can be guided by your primary care doctor. When it comes to pancreas cancers, patients who have a high-risk family history, meaning a pancreatic cancer diagnosis in 2 or more relatives, or who carry a high-risk pancreas cancer mutation, such as the BRCA or BRCA1 or 2 mutations, there are some recommended screening guidelines. And that includes an MRI or MRCP, alternating with an endoscopic ultrasound at your physician's discretion every year. And this can also be performed in association with certain blood tests or tumor markers, as well as an annual physical exam. And you should talk to your doctor more if you think you fall into a high-risk group for pancreas cancer. I know it's very scary to talk about cancer screening, but the important thing that you should remember is that you are much more likely to survive a cancer diagnosis if you undergo screening when you are at high risk and the cancer is caught when it's in the early stages. You might also learn information that can help a family member or a friend survive their own cancer diagnosis. For more information, use a reputable website like one from a cancer center or from the National Comprehensive Cancer Network's website.
Okay, sorry, the sound is not working, but you can go back to that page and click on the link and get it to play on your computer.
You said the sound wasn't working. I heard it pretty clearly.
I heard it too.
I heard the
Yeah,
sound.
it
It wasn't
very good.
was
The
it
sound was pretty good. Yeah, you
Oh,
got it, John.
okay.
Yeah.
All right, sorry about that. I thought it was
Yeah.
kind of low.
Yeah, the sound, I think what John is saying is that it could have been better.
Oh, well, I guess it always can be better.
It wasn't
But
in
the message was clear, and I think it's important to realize that nowadays we do have ways of picking up liver and pancreatic cancer earlier than we used to. Now,
Before we
yeah.
move from that, can I just share a short story with you?
Yes.
About 3 years ago, I had an ultrasound done of my belly, of my abdomen, and it came back that I had an abnormal liver reading, and they classified it as the fatty liver disease. I've never been a drinker, never been drunk, And it was just a puzzle to me how I came down with that. But I think mine was more of my diet that was affecting my liver. Since then, I had moved to, had started on an intermittent dieting program, and was controlling when I ate, how I ate, and what I ate, and also exercising. Through that program, I think I lost maybe between 25 and 30 pounds. My bone specialist had put me on some medication for my bone, and my gastro doctor wanted me to have another ultrasound of my belly, my stomach, to see if that medication was affecting my liver. I had that done on yesterday, and it came back that my liver was normal. No more fatty liver disease. Everything was normal. So I was really happy, and I'm glad you had this article, and I'm glad that I can share that information with you.
Wonderful.
Thank you so much. Thank you so much.
Awesome.
Yes. Okay. Nothing beats a testimony like that.
I was pleased with it, and the doctors there were also pleased with what they saw on the ultrasound.
So it was that bone medicine?
No, well, the he was afraid, my gastro doctor was afraid that the bone medication would have interfered with the performance of my liver, but that was not true.
Okay.
That was the reason for the ultrasound on yesterday.
Congratulations.
Yes.
Thank you.
Thanks so much for sharing. Thanks so much for sharing.
So Joyce, did the ultrasound tickle?
No, but they use some warm whatever they use to spread on your stomach to roll the thing around. No, it did not tickle.
Okay. This is an article that talks about lead tainted applesauce. And I didn't know the source of it, but it mentions Wana Bana cinnamon apple puree, which I'd never heard of before, but this was purchased in Maryland. And so I thought it would be important to share so that those of you who use that particular type of apple sauce, it is associated with a high level of lead, which of course is no good for any part of the body. And it has been recalled. But it's only the one banana, apparently, that is associated with the high lead level.
Yes. I've seen on the news for probably a week now about this applesauce, and I heard just yesterday that they found so much lead in their factory. And I guess that's where it's coming from, getting into the applesauce. But I've been hearing about this for maybe about a week now on the news.
Right. Yeah. Well, I just want to share it so that you'd think about it with your children and just avoid that particular type of applesauce. Okay, just a warning to parents and grandparents. Lead poisoning is not something that has harmed us for many decades, and it's another source of lead poisoning. Okay, let's go to the next one. Well, this is an article that has application for those who are going to retire and those who are already retiring. And they give you 5 what they think are good advices. When you get to the point where you think you're going to live longer than 65 and 75, the question is, can you take out too much too soon? And what age should you be shooting for. And this article kind of helps you take a second look at that, especially based upon your age. The first point is that don't take out so much when you're in your 70s, because you might live to be 80 and might live to be 90. So don't act as though you're going to die next year when you might die 20 years from now. Then the other comment is about not taking out enough, and how much is enough. And one of the things that's common is that you're required to take out a certain amount anyway. Uncle Sam requires you to take out a minimum amount of money. So you don't have too much choice in terms of not taking out any. You got to take out some. Question is, how much should you take? And then it's easy not to account for health care expenses, which are going up and up and up. Well, it's interesting because doctors, money that they get for healthcare is becoming less and less, but still healthcare expenses are going up and up. And so you got to keep in mind how much you have to spend for your healthcare. Then he talks about mistake number 4 is not changing your asset allocation, which means what percentage of stocks, what percentage of bonds, and what is conservative and what is radical, and I guess looking at what's happening to your money, seeing what is happening to your money. Is the amount of money you have in there going up or down, and why? Is your program too conservative or is it too radical? I think it varies, and I think what is important is that you look at your portfolio and make a decision about whether you want to be radical or conservative. The thing about being radical is that you can lose money faster. On the other hand, if you're conservative, you won't make money as fast, but you won't lose it as fast either. And then knowing which account to draw it from. These are all questions that it's easy to say, but it's hard to do. But what happens to many is that they outlive their resources because they think they were didn't expect to live as long as they lived. But managing all of this is easier said than done. And many people have financial counselors who give them advice as to what is too much and what is enough. But I think navigating retirement is something that depends upon what you bring in and how long you're going to live. And nobody knows how long you're going to live. So.
I had a question, Doc. Does anybody get interest on your savings? I remember when I first had a savings account, I could make money just putting money in the bank, and does anybody have a bank account that's savings, that makes money, that gets interest?
I don't.
No, I do.
What-
Online, but they're online accounts.
Yeah.
Like my Alliant credit, it's a credit union, and they'll give you right now they have an 18-month CD at almost 5%.
Thank you. Exactly.
And it's a Susie Orman. I'm sure you've heard of her. She they had a program where if you put in $100 a month, you would get for 12 months, you would get
Yes.
$100 in interest back.
Yeah.
I'm not sure if that program is still in effect right now, but she promotes the Alliant Credit Union, which is online. They're going to send you a debit card in case you need to, withdraw money from the account. But it's an online account, and you go in there. You can set up your beneficiaries and and that's only if you don't need the money. Put it that way. You don't need the money. So check out Alliant Federal Credit Union.
Excellent. It's federal.
Okay.
Okay.
I'm sorry, I have to look at Alliant.
Okay. Citibank, the bank I work with, Citibank, PNC, and the Bank of America. They have intermittently they have promotional or they have promotions. If you deposit, if you put away a certain amount, you get 5.6 or 5 point something percent interest. For instance, if you put away a certain amount like 200,000, you will get almost, for 11 months, you will get almost $12,000 back. So many banks have, these 3 banks I deal with, they have promotions, from time to time. Sometimes if you put away a certain amount for 3 months or 5 months, you get $500, in savings. Many banks have those promotions now.
Excellent. Thank you very much.
And of course, there's always savings bonds. They give percentages too, a whole lot more than just a regular savings account at a bank. And they have different levels of savings accounts, federal, U.S. savings bonds, but they have different levels that will also give you money. But thank the Lord that I am a retired federal government employee, and so I don't have to worry about those 401ks and taking money out and putting money in. My check comes once a month until I'm no longer here.
Well, I think this kind of good news is good for your health also. Thank you very much.
That's true.
Any other comments?
It
Okay,
seems like bank savings accounts are at the bottom. And the next level up would be CD savings and also credit union. They're higher. Navy Federal Credit Union is higher. But then on the very top, you have your investment savings account, where you got agents watching your money. Of course, you got to give them some money out of what you earn, but they're in the market. And I think Dr. Callender was talking about the market can be volatile. You got to watch out, make sure that you don't lose more than you are earning. Welcome, Janice.
Hello, good morning, everyone. Sorry I'm late, but I'm here. Emergency family.
I have one question. Especially Mr. Tatum, you might be able to help me on this this question. This pension we are receiving, well, as teachers, when we pass on, eventually, does our pension go to our spouses if our spouses are still alive, or does it just cease?
It mostly all of these accounts that you have, which Betty was talking about, pension and so forth, you have a beneficiary. You got to put a beneficiary down.
Okay.
And sometimes a second person. If that first beneficiary doesn't work. But no, you can put a beneficiary down on all of those accounts.
Oh, okay. All right.
Right.
Thank you.
If you don't put one down, then you have problems. But if you put one down, it can minimize the problem.
Okay. Thank you.
And I like to say I was working with a friend whose husband passed, and he had stock, and she was trying to get the stock transferred over to her name. And
Mhm.
she sent into them the death certificate and everything. And they said, well, if you're not the beneficiary, if you don't do that, even on your stock, then you're going to have to go through the courts. I was like,
Oh,
how in the world? I said, but this
okay.
is a spouse. They said it doesn't matter. And then I was just shocked that, you know, they wouldn't just transfer it over to her.
Yeah.
And you got to go through the court. So be sure you have beneficiaries listed on everything. Pay on
Okay.
death listed, and
Correct.
Okay.
I keep saying the government wants to keep your money.
Thank you. Okay. Mm.
I had a friend whose husband passed and he had a car in his name. And again, they were married. She had to go through probate. It didn't matter that she was his wife. Because I don't know how common that is, but that's what she had to do. This was like 4 or 5 years ago.
Yeah, normally I went to the DMV also with this young lady. You don't have to go through the courts if you're the spouse for the car. They will transfer the title over into the spouse's name.
She had a hard time with it, but it finally worked out. But
Yeah,
it was a few years
this was
back.
recent. This was
Okay.
recent this year, so maybe things have changed. But
Mhm.
I took her down to the DMV, and they just transferred the title in her name.
Good.
Oh, one other thing, they have a new form out that hasn't been out that long. TOD, transfer on death.
Mhm.
If you get a beneficiary on that form,
Mhm.
then when you die, you don't have to go through anything, no court.
Oh,
It's
okay.
transfer upon death. And so your
Okay.
property can automatically go to that person that you have designated.
Yeah, but that's only for DC residents. It's not for Maryland.
Okay.
Yeah, and let me say that transfer on death, it supersedes a will. And it's registered with, in this case, with the district. It is registered with the district and it supersedes the will.
Mm.
Oh, good to know.
Mm.
Okay, any other comment? Otherwise, we'll go on to this article that caregiving can be stressful, but it also lowers the risk of depression. And, we've talked about the fact that caregivers sometimes can predecease their people they're giving care to. And this can be stressful, especially if you have somebody who has Alzheimer's disease and you don't take advantage of the many opportunities to have people, group homes and other things to take care of some of that stress. But the other positive part of it is it's in giving that you receive, and it's in pardoning that you're pardoned, and dying you're born to eternal life. So that giving is something that is good for you, and especially if it's a point that you don't harm yourself in overdoing things and trying to take care of everything yourself. But it is important to appreciate that it isn't giving that you receive, and that there are positive aspects of giving that outweigh some of the negative consequences of putting others before yourself.
Dr. Callender. That's what I was involved in this morning. My sister has a friend, and I think I might have mentioned to you during the summer, he needs a kidney transplant, and he was on dialysis. His heart stopped for 25 minutes. And they worked on. They actually called her and said, "Get here now. He's gone." And they brought him back. And so he was in hospital for a couple of months and then rehab. But now, every day it's something. That's why I'm late. I was helping her. A couple of weeks ago, she called me. I live near her now with this new move. Fell in the driveway, busted his head open. Then last week, he was at dialysis. He fell down the steps. He falls a lot now. is that normal? They can't quite figure out what's going on. But after this life death episode, he loses function of his legs. There is a therapist that comes in, and he's been working with them, a physical therapist. And she said, I can't take it anymore. It is so stressful. And every day it's something. This morning, he fell in the closet. Okay. And he said, I can do it. I can do it. And if you push a chair near him, eventually he could pull himself up. And then there might be a couple of days where he can walk through the house on his own and not fall. Yesterday, was he at dialysis? What was yesterday? When? Oh, I mentioned to you too, and this is when you told me a few months back, which is true. I said his stomach will expand. And you said, oh yeah, it sounds like he might have a serious heart condition. Obviously now he does. And yesterday he went to have the fluid drained. After they finished that procedure, couldn't walk. So she had to leave here and go up to Bethesda Naval, get him, bring him back home. Might be a day he can walk around a little bit, and other days it's like the legs are rubber. And she is so depressed, very depressed. I tried to help her. What can we do about him? Is that normal?
Well, is that normal is the question. Let's just say that as you age, the things that you're talking about become more and more problematic. So it is what it is. And it sounds like it's going to have to make a decision as to whether she's strong enough to take care of him or whether he's going to have to be placed in a place that they will be able to take better care of him, because it's killing her.
It's killing her. And then the strange thing, like I said, this has been going on since July. And when this happened in the hospital, they wanted to know her relationship. And she considered herself his girlfriend. They've been together for 27 years. Of course, in the hospital, they said, oh, common law. It's the same thing. Just sign the paperwork. If something happens to him, you get this, you get that. And no, she didn't want to do that because I think he's not current with his finances. He always drags and paying bills, and she didn't know what all might have been out there that might have an adverse effect on her with her property and that sort of thing. And she's doing everything she can. But lately it's constant. So when he got home yesterday evening, I said, why did they send him back home? Because Thursday today is transplant day. So then they called early this morning and said, okay, don't bring him right back today. Bring him Friday. And because I told him, I said, if you had taken him back for his transplant after getting home at 5:30 last night and have to leave out at 5:30 this morning, his legs wouldn't be any stronger. But every now and then the legs are a little strong, but most of the time they're like rubber.
Now, did you say he had a transplant?
No, he was on the transplant list for kidney. Now he is not. The heart condition is so bad. Right now, he's not on transplant list. He does go for dialysis 3 times a week. But recently, and this didn't happen, this started, like I said, during the summer. So recently, the past couple of months, he has these bouts of weakness in the legs.
Yeah, well, I don't know the answer to the question except to say that it sounds like he's getting to the point where it's beyond her ability to stand it, and it may be time for them to find a place that is more conducive to taking care of him with his condition as it is.
And she sees that, of course, does not want to mention that to him. And then yesterday, he should have had his dialysis. He has the flu. They said it is not COVID, it's flu. And they sent him back home, getting excellent care. He goes to Bethesda Naval. And we say if it's good enough for the president, it's got to be good enough for him. And obviously, they've been working closely with him. but the stress that she's under is pulling her down.
Yeah.
And then I try to step in, and that's why I'm late. He had a little episode this morning. And yeah, caregivers go through a lot.
Yeah.
Yeah.
And I think you can't do it alone. When you get like this, she needs help. Maybe she needs somebody to be at the home with her to help her with, or there are other alternatives.
I don't know. We're trying to work through it.
Yeah, it's tough. I tell you.
It is. It is.
As you age, these things become more and more at issue.
Mm-hmm. Yeah. Okay.
This is we talked last week about the fact that we now have sickle cell gene therapy. And we also talked about the fact that the price for this type of gene therapy, there are two types, was close to $3.1 million. And we talked then about what insurance company would pay for it. And lo and behold, Bluebird Bio said that they would, at least Vertex Fund, would actually insure the amount. Of course, you're talking about price of $3.1 million. So at least those of people who have sickle cell disease who want to take this treatment have an insurer who will provide some of the monies. But I still talk about $3 million. That's not, hey, and how many of us can afford to spend $3 million on one medication? The answer is obvious. But so those people who were in the research part of it, they don't have to pay any money. But those people who are not, once the FDA approves this and it's no longer experimental, then the price is on them. So at least it's one thing to know that there is an insurance company that will deal with it. The question is, how many of those cases can it handle before it becomes bankrupt? And will other insurers follow suit? And so time will tell. And if you have friends who have sickle cell disease?
Yeah, I had some students. One of my students who eventually passed away, because of the disease, of the condition. That was in the 90s. It was a young female. She had the sickle cell condition. It was pretty bad, very, very bad. She lived up to, I think she was about 16 years when she passed on. Yeah.
Yeah. So, well, at least we're getting to the point where we're talking about bone marrow transplant and genetic treatments that successfully treat sickle cell disease, whereas when 20 years ago, there really wasn't any treatment except pain medication. So we're making progress. Now, this is a disease many of you have never heard of.
Prion.
But prion disease is a disease that is actually untreatable. It was a disease at first that they knew if it affected the beef, they had to kill the beef. But it's CJ disease is a disease that if you eat the animal with the prion disease, you'll get it, and there is really no successful treatment for it. And included this so you'd know that there is such a disease called prion disease, which is a protein disease that once it affects you, there really is no treatment for it, and it's lethal. So that's why if you have one cattle that has it, you kill all the cattle, and they can no longer be used for eating. And some people who ate cattle that had this disease have died. And just to let you know that there is such a disease, not a bacteria, not a virus, it's a protein issue that so far we have no treatment for it.
If Darryl were on the line today, he would say this is a good reason to be a vegan.
Right. Right. Yeah.
Is that like mad cow disease?
Yes. That's the other name for it.
Oh, okay.
Disease.
Yeah.
That's different from hoof and mouth, so right.
Some things we know about bacteria, viruses, but this is one disease, that protein disease, that we haven't learned any way to treat it. Okay, just to
They can
inform you
identify.
Hello?
that it exists. What was that comment? I didn't hear the question.
I said, thank goodness we can identify it.
Yeah.
Even if we can't treat it, at least we we can discover it and maybe keep away from it. But I remember it happened over in England the first time I ever heard about it.
And it's happened here in the United States,
Mm-hmm.
and mostly in the South.
Yeah.
Now, this is something that actually members of our group have been involved in clinical trials, and this is important. One of the nice things about COVID was that they did what was necessary to increase diversity in the trials for COVID, which is one of the most positive things that I've seen. And as a consequence, the vaccines that they prepared had the diversity that is necessary. But it is clear that we need more people of color in clinical trials. And so we need to do whatever we can to try to increase our participation. That's why it's been good to hear about a member of our group being involved with the RSV and other trials. So to the extent to which you can be involved in clinical trials, it is in our best interest. Because at first they didn't have women in the trials, and then they didn't have people of color in the trials. And of course, if it's going to be applicable to us, we need to be in the trial so that we know what we're getting into. Otherwise, it then becomes gender specific or ethnic specific, which is undesirable. Any other comments about this? Any of you who've been involved in the trials want to make any comments? Okay, well, it's sufficient to say that the more that we get involved, the better off it is for us.
Mm-hmm.
Now, this is something that's kind of obvious, but it's just important to recognize that if you have prediabetes, the management of it may be enough to prevent cardiovascular disease, which of course is the #1 killer in the world, not only in the United States, but in the world. And so if you find you have prediabetes, the management of that is sufficient to prevent you from getting cardiovascular disease. So take it seriously. if you have any of these conditions, pre-hypertension, pre-diabetes, anything like that, or non-alcoholic fatty liver disease is a good example. What Joyce shared with us is a great example of how an ounce of prevention, and then since non-alcoholic fatty liver disease is a preventable disease, a disease once you make the diagnosis can be treated, that this can make a difference. Any comment about this? It's pretty speaks for itself. But so when you have any of these kind of conditions, whether it's hypertension, dyslipidemia, and taking the medications for high cholesterol, becomes important.
You just mentioned that disorder I'd never heard of. What is that?
Dyslipidemia, fat. That means your cholesterol level is high. You can have high cholesterol or high lipid level, which can give you arteriosclerosis and coronary artery disease. And the treatment is to take statins or medication that lowers the cholesterol. And we have those medications now. So it's in the same category as, in other words, high cholesterol can cause cardiovascular disease. So therefore, lowering the cholesterol would be in the same category as pre-diabetes. You prevent the diabetic state, and if you have high cholesterol, lower the cholesterol so you don't get a heart attack, stroke. Now, this is kind of disturbing, that 20% of deceased patients listed as alive in electronic health records, which means that our electronic health records are not accurate. It's scary. But I think this means that we need to take efforts to make sure that the research and everything else that we're doing is accurate. And you can see that it's not something that should occur, but it does. So we have to be very industrious in keeping this from happening. Okay, next slide, please. Next article, 1030. This is positive. This is something that I never thought we'd see, where we have more years teens abstaining from drugs and alcohol, and actually even nicotine. The reduction of nicotine is going down to 5% from 9%. So this is nice to see that teenagers, maybe the consequence of listening to their parents or their grandparents, are not being involved in drugs as they used to. So that's good news. That's not too often we have some good news, but that's good news. Next article. Oh yes, and this is just as we go into the respiratory illness disease syndrome. This is just to talk about some of the symptoms that are common for COVID, which we now are all familiar with, although the symptoms are very similar. And let's hope that everybody now has the vaccination so that severe disease, hospitalization, and death become uncommon. But the symptoms are pretty much the same as they've always been so far. Sore throat, dry cough, and congestion, three most common symptoms. Okay, and so yeah, they do protect against variants, and you can see the mask again is becoming important. Washing your hands, ventilation, isolating for positive, staying up to date with vaccines, all important aspects of it. Okay, this is leishmaniasis is a disease that was thought to be only found in the tropics. It's a leishmaniasis is a worm, that parasitic disease, and they found it here in the mainland, which is unusual. But Texas is where there has been reported, spread by sand flies. No disease is desirable, but to have one like this that is so uncommon is something that is important. So we know how to treat it. And the vector, of course, again, is the insect, which is often the vector that causes diseases. Now, this does not involve us here, but people who in Texas might be concerned about it. Well, this is the last meeting before Christmas, which is Monday. And so I wish you all a very Merry Christmas. And we'll see you after Christmas, but may all of you have a Merry Christmas. This is the time of season when we talk about the memories of people who are with us and those who have gone before us. And I think it's good for us to keep in mind those who have gone before us and how they've contributed to helping us become who we are. And so even though we have lost many members of our families, Christmas is a time where we can rejoice in how they've helped us become who we are. And so it's not a time necessarily of sadness, it's a time of gladness in terms of keeping alive the memories of who've helped us become who we are, and passing on some of those wonderful memories to our children and our children's children. Any other comments as we wish everyone a Merry Christmas, and we look forward
Final
to
question I had, Dr. Callender.
Sorry?
One final question I had. I had a talk with my daughter yesterday, and she said her endocrinologist said that she had type 1 and type 2 diabetes together. She's taking this new medicine that you all have seen advertised on TV called Ozempic. And when they advertised it on TV, they said it's for type 2 diabetes patients. But her doctor prescribed that for her. She said she has not only type 1, but she has type 2 diabetes. And she said that it is helping some.
I see. Okay, that's interesting. You know, it's interesting to see. You say she has type 1 and type 2. Type 1 means you have no insulin.
Right.
Type 2 means that you have insulin, but that your insulin doesn't work for you. So it's kind of hard to understand having both of them, because type 1 means you have no insulin. Type 2 means you have insulin, but you have antibodies to the insulin. So.
Yeah, I'll go more in depth with it next time.
Okay, all right. But anyway, thank you all for joining us today. And we always have to thank John Buchanan for the mastery of the articles and putting them together. Buchanan is a genius who we're blessed to have with us. And we can't thank you enough, and we can't thank God enough for sending you to us. We're very grateful.
Thank you very much. Appreciate it. Happy holidays, everyone.
Yeah,
Happy
happy
holiday.
holidays, everyone. Okay.
Happy
Happy New
Right.
Year.
Happy holiday.
All right.
Okay.
Be safe.
See you next week.
Merry Christmas.
Merry
Thank you.
Merry
See you.
Christmas, everybody.
Bye.
Yes, Merry Christmas.
Merry
The
Christmas.
Christ of Christmas lead us all.
See you next week.
Yeah.